Hello everyone, I am Dr. Komal Majumdar and I will be speaking on fundamentals in tilted implants. Now, before we begin, let me first show the final result of some of my tilted implant cases. As you can see in this case, there's a atrophic jaw which is treated with Nobel Biocare implants, and this is the final post-op. Or in this case, as you can see, is treated with the Tooth Express protocol of Biohorizons, and you can see this is the denture which has been converted to a fixed prosthesis immediately after the surgery. Or in this case, which we have used a fast and fixed approach with the bio-HPP prosthesis and the patient has been given immediate temporization. Or in this case, with a freehand placement has been done of tilted implants, which has been successfully treated with a PFM prosthesis. Or in this case, where we have given lateral access channels in the final prosthesis, again treated with the tilted implant concept. Or this case with severe atrophy with both the upper and the lower prosthesis has been treated with maloprosthesis, and this is the case. This is the final prosthesis. Or the case with both the arches again, which are treated with tilted implants, and again delivered a final maloprosthesis. Now I showed you cases with five to seven different systems with follow-ups, and personally I find the concept of tilted implants a very predictable treatment modality. However, the late Carl Misch had once famously quoted, all on four or none on three. But now we know that there are studies to show, like this one, that shows that there is 99% survival of tilted implants, or this study that shows that even four implants are enough to restore a case. So, keeping this in mind, let's talk about the fundamentals in the tilted implants with respect to treatment planning, components, surgical phase, temporization, impression, and finally the final prosthesis. Of course, no discussion is going to be ever complete without the management of failures and complications. And finally, we will talk about management of extreme atrophy using the zygomatic protocol. Now, before we actually talk about the fundamentals, let's understand the evolution and concept of tilted implants. Now, initially in Brannemark in 70s started with 4 to 6 implants with cantilever, and a prosthesis was delivered in the atrophic jaws. However, we know that there are problems involved with such concept because of the extended cantilever, which can cause biomechanical failure in over a long period of time. And it was in 1999 that Matson decided the all-on-4 style, in which 15 patients were treated, and out of all these 15 patients, where 4 implants were placed, only 1 implant failed. Krekemer now in 2000 also showed that forces, whether you're placing 4 implants straight or tilted, the forces remain the same. And it was Malo in 2003 which started with the all on 4 concept with immediate loading in the mandibles. And after he got a good amount of success in the mandible, in 2005, he started also with the maxilla, in which 4 implants were placed. 2 of them were tilted on the distal aspect, and an immediate provisional was given to the patient. Now, what are tilted implants? Tilted implants basically are graftless implant procedure in which the posterior implants are tilted. Now, this is done basically to utilize the available bone in the anterior maxilla and mandible, which is much more denser than the posterior maxilla and mandible. The patient is given immediate provisional and is given immediate functional loading. Now, the question is, why do you really want to tilt the implants? And the answer is, the biggest reason is that it is acceptable to the patient. There is no extensive grafting which is required. The patient gets fixed teeth in a day. There are no second stage surgeries because all the components get attached at the level of the abutments. The biggest advantage is that there is minimized cantilevers and better oral hygiene for the patient. And for both the patient and the dentist, it saves a lot of time. Now let's understand really how both the tilted concept and the all on 4 or only 4 implants would work. Let's start first with the all on 4 concept. Now there are different studies to understand the forces on the implants, and the number of implants will be decided on how these forces really act on the implants. Now one of these studies was done by Brunsky, in which an undersurface of a prosthetic bar illustrating possible placement of 4 to 6 implants to support a prosthesis was used. Now, 6 implants were placed with a better AP spread, and the forces, both compressive and tensile, was checked on these. Now, four implants were placed with a smaller AP, and again, the forces on all these four implants, which are straight, were calculated, and the forces was definitely more on the four implants than as compared to the six implants. Now, again, these six implants were placed in a good AP spread, and now the next four implants, which were placed axial, were placed with a similar AP spread as that of four implants. And now, when the loads were compared between the four and the six implants, it was found that there was not much difference in the tensile and compressive loads. So, in conclusion, we can say that if AP spread is same for 4 to 6 implants, it doesn't really make any difference on the loads. Now, the question is, if AP spread is more important, can we use 3 implants with a similar AP spread? And the answer is yes, because stress on the implants is a factor of force and the surface area. In fact, if you look at the Novum system that was started by Brennemark, in which edentulous mandibular jaws were treated with only 3 implants and a fixed prosthesis were delivered. Now, the question here is, how did these three work? And the answer is that these three implants were used, the surface area of these implants was much higher. 5 by 13 mm of implants, 5 millimeter in width, and 13 mm of length of these implants were used. And more recently, the trefoil system that is used again uses the same concept, in which a prefabricated bar is provided to reduce the stresses on the implants and make it a more passive fit. Now, what about 5 implants? Can we really use 5 implants with similar AP spread? And the answer again can be concluded with one of the experiments that was done. Now, this one case is by Dr. Higuchi, who is the inventor of the trefoil system, in which 7 implants were placed in a patient. Out of these 7 implants, 2 failed and 5 implants were used to restore the case. And when the forces were calculated on these 5 remaining implants, it was found that the forces remained similar in both 5 and 6. So the conclusion as per the study showed that it was over designed and an inefficient way to treat a patient for a full mouth. However, you have to understand that the decision of number of implants and approach also depends on the age, the opposing dentition, parafunction, etc. So, how you treat a young individual who has lost all the teeth and how you treat a 70 plus geriatric patient will differ from case to case. Now, let's understand the concept of tilting. Now, really, can tilting really work? Now, it has been found that tilting has substantially lowered the forces on all the four implants relative to the non-tilting option, in which we see that there is about 50% decrease for the anterior implant load and 25% decrease in the posterior tilted implants. Now, tilting gives us a biomechanical advantage. And how does that really work? Now, we have to understand that the tensile and compressive loads on the implants depend on two factors. One is the AP spread, and second is the inter-implant distance. Now, higher the inter-implant distance, lesser are the forces, as it is inversely proportional. And second is the length of the cantilever. Now, one way to reduce the loads is obviously to reduce the length of the cantilever. And the second way is to increase the distance between the two implants. However, we have to understand that anatomy might not always permit us to give a good AP spread because of the pneumatized sinus or a inferior alveolar nerve which is placed very close to the crest. So, what we can do to reduce the loads is tilt the implant and place the implant, the apex, in the sound bone. Now, by doing so, what we are doing is we are increasing the inter-implant distance, because we have to understand that the forces on the implants is not calculated at the point where it enters the bone, but at the point where it is connected to the prosthesis. So essentially, by tilting the implant, we have reduced the length of cantilever and increased the inter-implant distance simultaneously. And again, as I had mentioned, that tilting substantially reduces the force on all the implants relative to the non-tilted options. Again, to repeat, it reduces the forces on the anterior implants by 50%, and there is a 25% decrease in the distal implants.